Welcome to the 10:45 or thereabouts press conference from ICAAC. ICAAC is the Infectious Diseases annual meeting of the American Society for Microbiology. We're coming to you live from San Francisco, California, and I'm Jeffrey Fox, the features editor of Microbe, the monthly magazine of ASM, and your host for many of these sessions. A couple of notes to those of you who are following us on the internet. If you would like to address a question to any of the panel members, please use Twitter hashtag ICAAC or use the ASM newsroom at ASM newsroom. Okay, so now this session we will be talking about HIV infection and cardiovascular health, and we have three people as our speakers, and let me introduce them. From the far end of the table is Charles Hicks of Duke University. Sitting to his right is Christy Kaiser, who is now of Georgetown University, but a former collaborator with Dr. Hicks. And sitting to my immediate left is Daniel Pearce of Loma Linda University in Loma Linda, California. I guess what I would like to do is begin the discussion with a brief summary from the three of you, although maybe we can make that just one of the two of you to begin with, and then from you, Dr. Pearce. So
Sure.
which of you would like?
I'm happy to start. Okay. So Christy and I at Duke were interested in cardiovascular disease in HIV-infected patients. It stems from the observation that people with HIV are doing so much better and living so much longer that some of the diseases that in the early years of the epidemic we weren't concerned about because most patients didn't make it long enough to develop them, now we're becoming much more relevant. And I also was concerned that much primary care now was being delivered in specialty clinics whose focus had been on HIV rather than a more broadly focused general medicine approach to patient care. And after a couple of patients that I had followed for a long period of time developed significant coronary artery disease, it made me much more aware that my skills in cardiology did not seem to be as contemporary as I would like them to be. And I was concerned that that was not unique to me, but perhaps those of us who were now doing more primary care in the setting of HIV infection really were not as cognizant of the best approaches for recognition and management. And so Christy and I decided we would try to investigate this in two large HIV clinics, the one we work in at Duke, but also our collaborators and colleagues at the University of North Carolina in Chapel Hill. And our approach was to look at patients who were HIV infected who went to cardiac catheterization because of either concerns about chest pain being coronary artery disease or because they were having a heart attack or having an acute coronary event. And then in order to give context to this, we thought it was necessary to have a HIV uninfected population drawn from people followed at the two institutions. The control population really came from Duke, who were of similar socio-demographic, economic status, racial distribution, and they made up our comparison group. And what we found when we looked at what had happened in those patients cared for in the HIV clinic compared to those cared for in the general medicine clinic was that a significantly higher proportion of those cared for in the HIV clinic at the time of catheterization either were having a myocardial infarction or having unstable angina, which is the prelude to a myocardial infarction, suggesting that opportunities perhaps to diagnose chest pain, to start the diagnostic algorithm, were not being taken advantage of by the specialty providers. Once the diagnosis was made, once they'd been catheterized and coronary artery disease was identified, the patients were managed in an exactly equivalent way. So we felt like it wasn't really a question of access to care necessarily, particularly because we made certain that patients had been in care for at least 3 consecutive visits prior to their diagnostic evaluation for coronary artery disease. So we didn't think it was really an access to care issue so much as it was perhaps a failure to recognize maybe the premonitory signs or the risk factors for HIV, and the fact that a higher proportion of the HIV patients really weren't diagnosed until coronary events were either about to happen or already underway suggested that that in fact might be true.
Okay, thank you. And would you summarize your findings, please?
Happy to. Years ago, I learned that the heart was the golden organ, that's where most of the money for research and care went. And I noticed that about 10 years ago that women were noted to have angina and heart disease, but they weren't being paid attention to as much as men were. So we were all told to pay more attention to women and angina. So we looked at HIV patients and mortality with an acute MI. We looked at the national inpatient, well, Dr. Hicks already summarized why we're looking at the heart with HIV. We looked at the national inpatient or the nationwide inpatient sample, which is a huge database of 20% of the patients in the United States, supposed to be representative of all the patients in the United States. And we looked at their, whether they're HIV positive or negative. We looked at comorbidities such as diabetes, hypertension, heart failure, peptic ulcer disease. We looked at demographics and hyperlipidemia, smoking, insurance, and other things. It's quite a heavy database study. And then we found that the hazard ratio for these patients dying was 1.38 times if you had HIV versus non-HIV. So if you walk into a hospital with HIV, you have a 1.38 chance of dying more than you do if you don't have HIV. And this is being controlled even for hypercholesterolemia and hospital type, which would be rural, urban, teaching, non-teaching, the demographics, and comorbidities. There also was another aspect to the study that those who just had MIs and didn't die, before they died, we looked to see who had MIs. By the way, those that died were 2% in the non-HIV group and 4% in the HIV group. There were about 600,000 HIV patients with acute MI and about 2.5 million patients in the non-HIV group. So it was a huge database study, but database studies have their limitations. So if they had an MI, there was less high cholesterol in the HIV group, the age was lower, and there was less smoking, and there was less antiplatelet therapy, antithrombolytics, and anticoagulation given to those patients. So we surmise that, we think about it because you can't say why they died and why they had MI. So there's been many mechanisms to show that there are endothelial and intimal problems with HIV, including cytokines and inflammation promoting cardiovascular disease in HIV patients. There have been some recent articles on that, and this is a hot topic in the literature. So basically, more death with HIV and you're higher risk. So we need to investigate why that is into a prospective double-blind controlled, not double-blind, but controlled trial.
Well, and when you say more deaths, you mean specifically from events from heart disease in this case. You're looking specifically at heart disease.
Acute MI and death. And they had to be admitted more than one day, so it isn't just coming in and dying. You had to be there at least one day and survive that. And we also looked at procedures too. The HIV patients had less procedures done, including cardiac caths, PTCAs, and just angiogram.
Okay, and that's because they had fewer procedures because they weren't getting the same quality of care? No, it's for some other reason, right?
This is just a database study, but we need to investigate that. Why? It could be a bias on the provider's parts, or like we had a bias against women, we weren't treating women correctly, or it could just be some systemic thing, or that the HIV or the medications are causing them to be sicker. And they won't qualify for the intervention.
I see. So there's some naivete in terms of how to treat this group of patients, and people are not thinking there may be a heart problem soon enough. They're not thinking that along those lines.
Not as alert.
Okay.
In fact, there's a recent study by, I'm sorry, I forget his name, that showed that they want to maybe include this in the Framingham calculation, that maybe HIV is one of those hotter risk factors compared to cholesterol, diabetes, hypertension, smoking, and family history.
All right, all right. So let's back off and talk more generally about what this phenomenon may be, that we have a group of individuals whose infection with a virus is being treated rather dramatically and radically with a barrage of drugs, of antiviral drugs. These are people who may have had a variety of infections, of opportunistic infections, fewer nowadays than before, but their lifestyle is not normal because of this underlying disease condition, and now because they are living longer, not falling prey to infectious diseases as they were a generation ago or 10, 15 years ago, they are suddenly showing up or recently showing up with heart disease. So what can we explore what you think might be going on here? There is something of an observation phenomenon that you have an opportunity to see this happening, but there's more to it than that, I suspect. So can we talk about that? Anyone?
Sure. Well, I think there are a number of possible explanations for at least our observation, which was that we didn't appear to address the diagnosis of coronary artery disease as expeditiously in the HIV population as in those who were not HIV infected. One is that coronary artery disease appears to occur earlier at a younger age in persons who are HIV infected. In fact, when we tried to find a control population, one of the most difficult criteria to try and replicate was to find people of comparable age who were having cardiac catheterization for chest pain. The median age in the HIV-infected population when they had a cath with coronary artery disease was 49, which is not young, but not so old either. And so the disease pace appears to potentially be accelerated. And I think our mindset is not quite so much to think about someone with chest discomfort who's 38 or 41. Should we start thinking about heart disease, or do they have a musculoskeletal strain or some other? Yeah. So I think part of it is we're not tuned into the idea, and because the patients are younger, we may not begin to think about coronary artery disease in the same way. But I also think that that having HIV in general causes immune activation and a generalized inflammatory state to be present. And this is obviously modulated down with successful therapy, but it doesn't really restore itself to pre-infection levels. And coronary artery disease, at least in part, is driven by inflammation. So there may be an overall more global explanation for why this appears to be occurring earlier. From a clinical perspective, I think just trying to sensitize people to both the prevalence of coronary artery disease in the population, but also for the potential for it to occur earlier might allow us to start thinking about it and how we might take advantage of diagnostic tools earlier.
Mind if I add to that?
No, not at all.
There was a recent study put out at the last International AIDS Conference by O'Brien that showed that there's there's a platelet dysfunction in HIV also. So not only is the endothelium having problems with inflammation, but the platelets are also having a problem. And also we didn't mention medications may be causing the problem. I use the term barrage of medications. I know the list is huge, but we're only giving 3 or so medications, and these are very well tolerated. So barrage might give the wrong, impression that it's very toxic.
Okay, no, fair enough. Okay, I had a question, but while the microphone is coming up to the front of the room here, let me follow up on something you just said about inflammatory responses, or that these patients have greater responses. And I want to follow up because I think of HIV as damping and quieting, shutting down the immune system, and you are implying that there are, in some cases, heightened responsiveness. Can you help resolve that?
Yeah. So I think, and please correct me if I'm reading more into your comment than is correct.
Oh, it's a naive comment.
No, well, in the down regulation, if you will, of immune function, I think, is a consequence of people having the infection, having damage to the immune system, and over time eroding some of the capability of the immune system. And that certainly happens. But from the start of the infection, when the virus is first acquired, to that immune destruction, deterioration, is quite an extended period of time. And during that time, markers of inflammation, markers of immune activation tend to be very high. So in the background, the body is fighting a furious pitched battle against the virus that lasts for years. And the immune system can't just say, okay, we're going to only attack this particle of virus that seems to be the culprit. It's turned on in a much more profound whole body sense. And so the consequences are that conditions that are mediated by inflammation, including coronary artery disease, are probably, it's predisposed for them to be occurring with greater frequency because of this ongoing massive immune activation, inflammatory state that's present in people with HIV.
Okay, good.
Even though we put the cap on the jar of bees, we control the HIV, there still are problems. We have more cancers, we have heart disease, kidney disease. We think, oh, gee, if we control HIV, that's the rest of their life, bye-bye, everything's fine, you'll live just as long. We still have to monitor them. There's much going on that we don't know about.
Okay,
that we know about.
Let's take the question, please.
Sure, I have a couple of questions, if I may. Michael Smith from MedPage Today. And my first question is actually for Dr. Hicks and his colleague, and that is, you saw a significantly increased rate of MI and unstable angina in the HIV patients, if I heard you correctly.
Rate probably isn't the right phrase. Rate implies a numerator and a denominator. I think what we saw was that among people who went to who went to catheterization for chest pain or concerns about coronary artery disease, the proportion of them that actually had the disease at the time of the procedure was significantly greater than the proportion of people in the other population. It's kind of like, if I can draw an old analogy to appendectomies. When I was a medical student, they were teaching us about evaluating a patient with a possible appendectomy. The teaching was if 100% of the people who have an appendectomy have an abnormal inflamed appendix, then you're not doing enough appendectomies, because there are obviously other people whose presentations may not be quite so alarming that you say, well, I'm just going to hold off on this surgical procedure. And then so that means that if everyone you did was positive, your threshold for doing them is not enough. And I think you could apply that to evaluation for coronary artery disease. If everyone that you evaluate has the disease, it suggests that your threshold, your inclination to do the procedure needs to be set lower, because you want to make sure that those who are kind of in the intermediate state are also being seen. So my concern about the differential is that the HIV population, we're either not recognizing the disease at time, or for some reason we're not employing the tools of diagnosis, because we don't want them to have the procedure after they've already had injury to their heart, a heart attack.
Actually, that was just sort of
I'm
making
sorry,
sure I understood.
Yeah.
My question actually is then, I'm wondering if you then said that they got the same care as the people in the control population, so there was no difference in care. I'm wondering if you looked at or were able to see any evidence of Dr. Pearce's findings in your population. Did you see
higher mortality?
Higher mortality.
Yeah. Christy, can you?
We did not measure mortality, but it is interesting that our results seem to be a little bit different than his, in that once the patients were diagnosed with coronary disease, the management was the same, because we wanted to know, is there a prejudice towards being less aggressive with the comorbidities in HIV patients? And we found that the same percent went to bypass surgery and the same percent went to have stenting done. So that's why we felt that it was maybe more not being aware of the risk factors and all that, but once they had the disease, they were managed the same.
Okay, thank you. Then the general question for both groups, if I may, did you look at control of viremia? Was there any effect of treatment, HIV treatment, on your outcomes?
Yeah, so that's a really, really good question. I think it gets to the heart of the matter. The short answer is that's not something we've completed the analysis of, but I do think it raises several ancillary issues. One is concerns that some of the medications used to treat HIV may be associated with greater risk of coronary artery disease, either because they change the lipid profile in ways that are deleterious to the cardiovascular system, or because there's some intrinsic property of the treatment that may associate itself with higher rates of coronary artery disease. The numbers we had, we were about 100 HIV-infected patients. Once you start breaking them down to try and ask those kinds of questions, your sample size just becomes too limited to really make statements about that are definitive. I think in some ways what we have done so far is quite interesting in the sense that it's so-called hypothesis generating. We see this difference now, and why that might be so, and what differences may exist within just the population that are HIV infected, I think are as yet unanswered questions, but certainly this is kind of the next step, the direction in which we're going. Our hope is that now with Christy having moved to Georgetown and with some colleagues here in California, we're going to try and get a larger population, be able to address some of those very important HIV-associated issues.
But I can add that the median CD4 was about 500, so it was certainly not, most of the patients had well-controlled HIV.
Right. Do you have a...
We in this database where we were unable to check for their AIDS status or their viral load or CD4 status, so we can't comment on that. And we weren't able to check for substance abuse because, as you know, stimulants can cause acute myocardial infarctions. Did you check for substance abuse?
Yes.
What'd you see
Well,
there?
we have with cocaine is what we looked for. I think it was 10 to 15% in the HIV group had used cocaine within the past year.
Yeah, the cocaine, Christy has it almost exactly right. 17% of the HIV-infected patients in the population had cocaine use, and it was 10% reported cocaine use in the non-HIV population. Not statistically different.
And maybe that's the reason why, because we know that HIV patients smoke more in general, you know, the higher proportion does, and use drugs more. So maybe that explains our disparities that we're having. So we need to check this out further.
We also looked at that
Smoking?
a little bit. Yeah, smoking.
Go ahead.
51% of the HIV-infected patients in the study group were current smokers, and 37% in the HIV uninfected population. So it's different, given our sample size is not statistically different, but certainly the traditional risk factors are at least part of the problem. I think that's fair to say.
Our smokers were statistically significantly different, that the HIVs were less than the non-smokers, showing that maybe something else is causing the MI. Maybe it was cocaine or stimulants. But we know that in general, HIV patients have a greater proportion of smokers. So why are our patients with acute MI less smokers? Maybe because they're being hit early before they start smoking. I'm not sure what's going on.
We have another question from the room.
Dan Keller, Medscape. You only had 96 HIV positive patients. Is there any way you could just look at drugs overall in terms of duration of therapy or time between diagnosis and therapy and break it down that way as opposed to by specific class or specific drug? And the other thing is, how do you reconcile the unstable angina and MI findings at catheterization versus what you called significant CAD, which did not differ between the two groups?
That's a really good question. I'm going to let Christy comment as well, but I kind of always take over these things, so I'm sorry. There was a difference actually in the rate of so-called significant coronary artery disease. It was not statistically significant. I think it's a sample size issue. So by significant coronary artery disease, we said they had to have at least a 50% obstruction in one major vessel, and the overall rates were 63% had significant coronary disease in the HIV population versus 54% in the HIV uninfected. Because, again, we're talking about 96 versus 49, it's not a statistically significant difference, but it's tantalizing. And I think if you believe that that is trending towards a difference, I think that's kind of supportive of our notion that, gosh, I wish we'd thought about this earlier and launched the diagnostic algorithm. before that extra 9% had developed significant CAD, but that's really speculation. Christy, do you have any?
Just to answer the first part of the question, as far as the medications, about 85% were on antiretrovirals, but we didn't break it down by specific type of medicine just because of the small sample size.
Yeah, that's a really good
Yeah.
idea. And the other thing I'm interested in is the amount of immunologic damage that's transpired by the time they start therapy, so nadir CD4 count. And this whole viremia copy year, I think, are really interesting areas for us to explore. Thank you, that's a good idea. I think we'll do that.
And duration of good control maybe too.
Sure.
We have another question.
Hi, I'm Liz Heileman from HIVandhepatitis.com. I'm wondering if you could sort of boil down a soundbite for what kind of clinical recommendations you might make for people treating HIV and patients with HIV.
I think we all agree, be more alert with HIV patients in chest pain or cardiac disease, cardiovascular disease.
Yeah, and I also wanted to add that we were surprised that it was harder for us to find control patients, actually, and one of the reasons, which Dr. Hicks mentioned, was that it was hard to find patients as young. But the other thing was that we had required that they be plugged into care before going to cath, because basically we wanted to know, once the providers had access to the patients, was there still a discrepancy? And we had to exclude 3/4 of our control group because they were not plugged in already at the time of cath. And I think especially if you have, young men who have a low socioeconomic class, they usually don't go to the doctor. So with the HIV positive group, you actually have a really unique opportunity to get the patients when they're early, because they're plugged in for their disease at 30, 40 years old. So ideally, we should really be catching the disease even earlier in those patients instead of later.
Right, I think that's a really good point. So when we were trying to find our control population, our criterion was that they had to have had at least 3 visits prior to their going to cardiac cath, so that the provider had an opportunity in their interactions to determine that coronary artery disease may be an issue and therefore take them to whatever diagnostic approach seemed appropriate. And as Christy mentioned, most of the people in their 40s and earlier who weren't HIV infected did not tend to be seen by a physician or healthcare provider unless they had some other disease, like diabetes, like end-stage renal disease, like ongoing hypertension. And again, because our focus tended to be on a comparable socioeconomic demographic to that which we follow in our HIV clinics, the interaction between the healthcare system and the patient tended to be a little more chaotic, and so we had a difficult time getting a good control population.
With the new healthcare law, though, 30 million people or so have more access to healthcare, and I see a lot of young people getting primary care now, but maybe not enough to study them. Can I ask a question? Over here. May I?
Can I give an answer?
Yes.
Well, you nodded your head. I
Okay.
thought.
No.
My entry criteria was if they have acute MI. Your entry criteria was if they had a cath, right?
Right.
So therefore, you're going to already, yours took that next step, and so you've already screened out a lot of people who didn't go to cath.
Right.
So I think maybe that's why we may see a disparity in less procedures, because if you're going to do one procedure, then you may do the second procedure. But my patients, less of them had the first procedure. Does that make sense?
Yeah.
Yeah.
I wanted to ask a question about sort of early diagnostic signs of heart disease, coronary artery disease. It seems as if these patients don't show a typical profile of people who are not HIV infected, so that you have some inkling that they might be at greater risk for this kind of disease. Is there some pattern emerging there, or did I misread things?
No, Christy is the one who did most of the review of the charts per se. So how do you, would you say the presentation among the people who are HIV infected was more often atypical?
No, I would not. And we didn't look at the specific quality of the chest pain or the shortness of breath they presented with. But we do know that although there seems to be a slightly higher risk in HIV positive patients, the majority of their cardiovascular risk is still the traditional risk factors. So it's really, I think, to kind of get back to your question about what kind of soundbite would we hope people take away, I would say if the infectious disease providers referred their HIV-positive patients more systematically to a general medicine doctor to be seen, even once every other year or so, even if they don't have clear other medical problems, just so that they can do a more systematic preventive medicine screening, including cardiac risk factors, because it's the same things that you would look for.
Yeah, it's an interesting point Christy raises, and it's kind of where I think we're kind of at a divide point where now that HIV-infected patients, the actual day-to-day management is in general much simpler than it used to be. Someone gets on a successful regimen, looks like those tend to be quite durable. You just continue the medicine, encourage adherence, follow their laboratory profile. More and more patients now are being managed by specialty doctors who I think still have blinders on a little bit. And the question either is, do we try to get the specialty doctors more broadly focused, have educational efforts to sensitize them to coronary artery disease, cancer screening, and some of the things that are part and parcel of being a generalist? Or is it appropriate for many HIV-infected patients not to be followed in specialty care, but to be followed by a generalist who tends to do those sorts of things more efficiently and only go back to the infectious disease or the specialty provider when there are issues specifically relevant to that? And I'm not sure what the best answer is, but I do think as we model how healthcare delivery is being done for the 1 million+ HIV-infected patients in the United States, this will be an important thing to discuss, and a pattern developed which is able to end up with the best outcomes for the patients.
As a primary care internist HIV specialist, we give primary care to our patients, so maybe doing electrocardiogram early, maybe having a lower threshold for starting aspirin once a day might be a good idea on these patients. So that may be a practical issue or application.
All right. Well, I think that's probably a good point to wrap up. Unless there are other questions? No more questions. So just to remind everybody, we've been talking with, at my far left, Charles Hicks of Duke University in Durham, North Carolina. His former colleague, but continuing collaborator, Christy Kaiser, who is now at Georgetown University Medical School, I guess, in Washington, D.C. And then to my immediate left, Daniel Pearce of Loma Linda University in Loma Linda, California. Thanks very much. That wraps up another ICAAC Live session. We have another one coming up at about noon West Coast time. Thanks very much.
Explore the fundamental role of microbes in the natural history of our planet with Microbes in Evolution, the world that Darwin never saw. Available at estore.asm.org.